to keep those germs at bay. Get more tips for healthy living by tuning in to Kaieteur Radio every Monday at 1:05 p.m. for Your Health Matters.
Good day, listeners. Welcome to the program. I'm your host, Rehanna Ramsay, and joining us in studio today is Dr. Shivani Samlal, a gynecologist and oncologist. Her area of focus is gynecological cancers. While our discussion in today's program will focus on cervical cancer, Dr. Samlal will touch on the other types of cancers affecting the female anatomy. Welcome to the program, Dr. Samlal. And could you share with our listeners a little bit more about yourself before we go into our questions?
Okay, thanks, Rihanna. I'm from Esquivel. I was born in Esquivel in Coffee Grove, as a matter of fact. Attended Androgina Multilateral School and was subsequently awarded a scholarship to study medicine in Cuba. I would have finished in 2009, but we came back a year earlier in 2008. I worked in study for a brief period of time, then moved to town, did a few training courses in cervical cancer prevention and screening and so on. I started residency subsequently at GPHC. Then later on went to Cuba again. Following my residency in gynecology and obstetrics, I subsequently pursued studies in gynecology oncology, 1 year in Cuba, and following that I did a master's in Spain for another year. So here I am.
Okay, that's great. So today we'll be talking about cervical cancer. And just for those who don't know what it is, could you give us, in your words, what is cancer of the cervix?
Generally, we'd say cancer of the cervix is cancer to the mouth of the uterus or the womb. It's basically that area, it's almost like the tip of the nose, and that's the part that when women are in labor, that's a part that they check to see how far you're dilated. So generally, it's just cancer that is located at the mouth of the womb.
Mm-hmm. And for this type of cancer, every illness would have symptoms. What kind of person look for in terms of symptoms?
Okay, generally, I think what people need to understand is that initially they might be very mild symptoms, and so people really aren't, thinking this may be cancer, if at all they experience symptoms. Because most times when people come to the clinic, if they're not doing their routine PAPs or so on, and it's not detected early, is when they're referring heavy bleeding or so on, and that's when they have advanced disease. But I mean, the milder form of symptoms is that patients can have some watery discharge, maybe bleeding during sexual intercourse, maybe some spotting, occasionally some pain. So generally those that can happen if the disease has spread. Patients can have more severe symptoms like shortness of breath and back pain and so on. But initially, most of the symptoms are so mild that they're undetected if the patient isn't being screened.
Mm-hmm. So because they're undetected, how often would you recommend, or how early should somebody be screened?
Okay, so generally their recommendations are constantly being revised. Initially, it was at age 21, and that has been revised because prior to that age, about 1% of persons are diagnosed with cervical cancer. And when persons undergo that screening, what happens is that they're if they're detected with the HPV, they're like so much stress and emotional and psychological, effect of being diagnosed with the HPV virus at that age, and they undergo subsequent screening and treatment and so on. And so there's a lot of studies that have been shown that it doesn't make sense to put women through this torture to get screened before age 25 or starting at age 21. So the recommendation has changed to initiate screening at age 25. Generally, you start there. It depends on what screening tests you use. We in Guyana use the VIA, and generally, if the test is negative, they would recommend that the patient come back every 5 years. If patients have an alteration in their test or they're HIV positive, then they usually come back yearly for screening. If we do Pap smears now, Pap smears are done every 3 years. If we combine Pap smears with HPV testing, that is generally every 5 years. And if you do HPV testing alone, is every 5 years. So it depends on, which screening modality you use to detect cervical cancer. What is really being pushed for right now is for primary HPV testing. And that's what international recommendations are. In Guyana, as I said, we do the VIA. We don't do it as a screen and treat approach. Most lower income countries use this because it's cheaper and you can get the resources and so on. But the idea of using the VIA was that once you detect somebody, you screen them. Once you detect a lesion, you can treat that person right there. But unfortunately here, we only have one facility that offers that service, and that's a GPHC. So all the other areas, when you do screening, the patient has to be referred subsequently to GPHC, which shouldn't be.
And you touched on HPV, but for those who don't know what HPV is, it's the actual virus that causes cervical cancer. So, but we know that this HPV is just not one strain. So for persons who might be at risk or would have contracted the disease, the virus, they need to know that it's not everybody that has it would
get cervical cancer.
Could you share a bit on that?
Sure. So HPV is a human papillomavirus. It is a sexually transmitted virus. So, and I've said the statistics is once you're sexually active, by age 25, 90% of us would generally get this virus, but not all of us would develop cervical cancer. To get cervical cancer, basically, you have about 13 to 14 high-risk types that cause cervical cancer. Of those type 16 and 18, they're responsible for the bulk of cervical cancer cases. So yes, and the other question you asked me regarding that was, what you said, not everybody would develop. So it depends on patients' immunity status, meaning if they have a strong immune system and don't have other diseases and so on, that can lower their defenses to fight off this infection. And it will take this infection to be very persistent. So patients not be able to respond well to the virus and clear the infection. So yes, those are the ones that tend to progress. And of those types, as I said, 16 and 18 are the very aggressive ones. So they tend to persist, and they cause the bulk of cervical cancer cases.
In terms of risk factors, is heredity a risk factor for cervical cancer, or what are some of the other?
So that's something to elaborate on, because lots of persons would come and say, oh, their parents have a strong family history and so on of cervical cancer, but there hasn't been enough study to show a genetic component with regards to cervical cancer. So since the 1980s, it has been studied, and we know the main cause of cervical cancer is the HPV virus. So family history, not a strong component in terms of, cervical cancer. So patients can rest assured, having a family history and so on, that they're not at risk. However, other factors are like, for example, if patients started having sex at a very early age. And the reason is that your cervix is more exposed, the area where cancers develop are more exposed when you're younger. So by having sex at an early age, there's more exposed tissue of the cervix to the HPV virus. So that's one risk factor. Others are like, for example, if persons are promiscuous, if they have various sexual partners, or if you're okay, but your partner is promiscuous, or he has various sexual partners, having STIs. And it's basically, if you have other infections, they tend to cause, irritation to that area, and
Compound the issue.
and it also increases your risk. Yeah, definitely. Patients who smoke, party, the more kids you have, it's been shown that the more at risk, and it's because of the hormonal state of pregnancy, and also the trauma that happens to our cervix during delivery. And HIV status, if patients are positive, or if they have any other immune disease, as I was saying, that will lower their defense systems, like autoimmune disease, or they use steroids. So persons who are on the steroids for a long period of time, their immune system is not as strong as those who wouldn't be on that kind of treatment.
And to tackle the disease, we would have, by we, I mean the Ministry of Health would have rolled out a campaign to vaccine campaign, the HPV vaccine campaign, a few years ago, to try and tackle it early. Could you speak to the effectiveness of this vaccine, or today?
The campaign or the vaccine?
No, the vaccine mostly, because
yeah, okay. So they have I think piloted I can't remember exactly what year, but in 2015 I think they had started. They included boys in their campaign to be vaccinated also. So I think they've done a pretty good job in terms of vaccination. However, there were some resistance in terms of getting the vaccines and so on. And everywhere you go, every country, there are anti-vaccine or vaccination campaigns. Persons who don't recommend vaccines, and that's where the myths of all what the vaccine does comes into place, and we can probably talk about that later on. So they have been pretty good, but I think they had a lot of effort that came in from private persons and so on to actually push for persons to be vaccinated. So I'm made aware recently of persons who went around trying to get signatures and present that to the ministry and so on, so for them to be able to develop a program, to introduce these vaccines. So, but they have done a pretty good job. I think what we can use as in terms of making this bigger effort and capturing more persons is adopting a strategy similar to Australia. Australia is one of the countries that's way ahead in its way of eliminating cervical cancer. And WHO has a plan to eliminate cervical cancer in another 100 years. 100 years may seem like a really long time, but once you start implementing that plan now, I mean, by the next 5 years, you would have saved about 10% of women of the actual figure right now 10% of them would not be dying. So you'll be saving as you go along on this strategy, even though if you're implementing it today, you'll be saving lives 10 years from now, 20 years from now, before you eventually eliminate cervical cancer. So back to Australia's story, they are one of the most successful countries with regards to this vaccine. And they did a lot of awareness. And they might be the first country that will probably eliminate cervical cancer and before another 100 years. And so we can look at these countries and learn from them. They had initially, when they introduced the vaccines and to boys, they had anti-vaccine campaigners and so on, and persons who reported it into the media. But the good thing with them, they had backup plans. So they anticipated all the what you will say, pushbacks. They anticipated them and they planned for them. So when one of the reports where patients, teenagers had fainted and so on, they were able to be seen, make arrangements for those patients to be seen immediately. And, news report came out immediately that it was just a dizzy spell and nothing serious or life-threatening. And the ministry and everybody came on board. So they had not just awareness in terms of this vaccine, but they had backup and support system anticipating any challenges that would arise.
Well, you know that vaccination or immunization is always a topic where people are quite suspicious of taking a vaccine because they don't know the risk, the side effects, the risk involved and all that. So I don't know if it's probably that was one of the factors that would have affected our campaign. But do you know, in your estimation, what can be done? Because you spoke about awareness to address that issue, because people don't know.
Yeah.
They hear about HPV. It's not something that is widely discussed. It's not like COVID-19. Everybody knows COVID-19.
Yes.
But HPV is something that is not something that is widely, known. So when a parent hears their child has to get a vaccine and they have to sign off on it, they're suspicious, they want to know more. So is it that, in your estimation, that these parents, the ministry needs to interface with these persons more? I
think there's a lot. There needs to be sensitization and a lot of sensitization towards the vaccines. And earning public trust is very important, and maintaining that public trust, because you can't just come out and say, it's a safe vaccine, and then something happened, and then you don't inform the public and so on. And so there should be transparency also in terms of this process. People need to understand that, taking the vaccines, they're safe, and there are studies, as I was saying, these vaccines are not, it wasn't born or created overnight. Like the coronavirus, the vaccines were developed in a period of a year and over, and developed, tested, and had trials and so on, and are being administered right now. These vaccines for cervical cancer has been around since 2006, and they were already studied number of years prior to the official FDA approval for these vaccines. And on top of that, these vaccines are continuously being studied, because if someone has, say, I'm doing a campaign right now and I'm administering this medication, this vaccine, and a patient has a side effect, that has to be reported. And then that is subsequently taken on a committee, and they have to decide if doing studies and so on, if this side effect was secondary to the vaccine or not. So it's continuously being studied, not tested. And they have been continuously shown to be very safe and effective in terms of preventing cervical cancer. So people, I think, need to understand that they're safe. And the side effects of them are very minimal. It's basically the same thing that people are reporting with any childhood vaccines, or if you have any kids and so on, when they have a measles, mumps, these vaccines, they have a little soreness, a little bit of swelling, and they might have a mild grade fever and so on. So the effects are similar to any other vaccine that exists, and the only other thing that that in the case of Australia, with the patients who had to be rushed to the hospital, was their disease spells. And that's been very much common in the population that are injected. So girls, they would probably, have their menstruating. They might have different episodes that happen during teenage years and so on. And it doesn't even have to be secondary to the vaccines, but they still recommend that after the vaccine, you just sit down for like 15 minutes or so to avoid that feeling. So safe and effective. And the outcome is prevention of not just cervical cancer, but other types of HPV-related cancers as well.
You say cervical and I say cervical, but both are correct.
Yes, different.
Because people might hear us pronouncing it differently and think, oh, what's the right?
No, there's the same thing. Okay. Yes.
And we would have mentioned the boys having to take now, and I'm not sure what was the outcome for that, because this is generally a female ailment. So I don't know if you can speak to what are some of the responses in terms of boys getting the vaccine.
So the logics behind boys getting the vaccines. Ideally, the targeted age group is prior to the initiation of sexual activity, because that's when the vaccines tend to be more effective. But you can still give the vaccines after, including boys. Is that it's shown that HPV not just causes cervical cancer, it causes genital warts also. So, and that happens for both male and female. So by administering the vaccine to boys, you're preventing them from having genital warts. If they are with partners and they're getting the vaccines, and say the partners didn't receive the vaccines, they'll offer protection to that person. And also, there are other related HPV cancers. So there are oropharyngeal cancer, which is mouth, throat, and so on. I think Michael Douglas, that famous actor, he had a HPV-related throat cancer. And so you prevent that from happening. There's also HPV, other cancers that guys get from the HPV, and there's penile cancer, anal cancers, and so on. So they benefit. And they benefit from the vaccines. They contribute to the benefits also for the females. And there are studies that have done and shown that if most persons are vaccinated, the unvaccinated population are also protected from the virus. So that's what you call cross protection. So the more people that are vaccinated, the better. And this does not go for the prevention of cervical cancer alone. So that's another thing that people need to understand.
So that's a benefit.
Yeah, very beneficial.
Okay. So we'll go to a short break, and when we come back, Dr. Samuel will share more with us on cervical cancer and the other types of cancers affecting the gynecological sphere. Your Health Matters. I'm your host again, Rehanna Ramsay, and we have Dr. Samla with us, and she was telling us about cervical cancers, the risk, and the possibilities of testing and other stuff associated with getting treatment and so on for the disease. And we were talking about treatment a while ago. And so she shared with us that VIA testing is what is available for most persons in Guyana. It's in the public setting. So I'll ask her now, what are some of the other treatment testing options available to women who want to know their status as it relates to cervical cancer? Go ahead, Dr. Samuel.
Thanks, Rehanna. So as you said, VIA is what's being used in Guyana, and it has worked. And VIA is basically just looking at the cervix and applying some vinegar and basically observe the cervix for changes. Mm-hmm. It's a very simple test, very easy, and persons can get their results in like 1 minute. The problem that you have, or the issue that you can have, is that inter-observer discrepancies. So I might look at the cervix and say, oh, this probably looks positive, or this probably looks negative, and there's that discrepancy that can exist between one person and another. But generally, it's a good screening test. If not, it wouldn't be used as screening for cervical cancer. Similarly, with the Pap Smears, they have that difference too, because it depends on who's looking at the slide under the microscope, So it has that. And so Pap Smears are generally available at most private institutions. You can get Pap Smears, I think, Sigma Labs, private clinics, private hospitals, and so on. It's not a test that's readily available at the public settings. The other screening modality is the Hpv testing. And as I said, this is what's being pushing for in a lot of countries, because if you do this test, the Hpv testing, and it's saying that, okay, I don't have no high-risk types, then you can just observe that patient and let it return. And that doesn't depend on me and you. It's just, it's what's recorded by the lab. You understand? So it is very much a better test. It's far more costlier, of course, and for low-income countries like ours, it's very hard to use as a screening tool for the general public. Mm-hmm. But it is a really good test, and so depend on that results. If I don't have any in 5 years, if I have high-risk types, then I can decide, okay, I'm going to do a Pap smear for this patient, or I'm going to do a biopsy, depending. So those are the tests, and the HPV testing, I think, is done also at Sigma Labs. I'm not sure if any other center offers the HPV testing.
There were recent, last year there would have been reports about a company bringing in self-tests for HPV, for cervical cancer, and I don't know if you were aware, and what would you say about having, and how effective, how good it would be for our setting, our local
so
setting?
I think I saw something on that, and I think it has a lot of benefits, and also there's some downside to that. In Guyana, as you know, not everybody has access to testing. And say I live in the interior and I came down and do a HPV self-testing, or say you take the sample in the interior. Ultimately, depending on the results, which I think has to be sent out and you have to wait, if that patient is not able to come back and pick up her results or get her treatment, that's the the disadvantage of the test. So one is that it's good. A lot of countries are using this with success because they're capturing more women. Basically, you could take the sample and you can mail it in or mail it out. The only downside to it is that the sample is not processed here. It has to be sent out. Patients have to wait for the results. And if you're doing, as I was saying, if you're doing the screening for women in the interior and so on, then how they're going to get treatment. So there's this always loss to follow-up that happens. So that's where a good cancer registry, a good backup system so you can record these women and so on and keep track of them. So it's not just having these tests, you have to have good registry and to track these patients and ensuring that once they're tested, positive, that they have options in terms of treatment and they have access to these treatments. Mm-hmm. So that's why we come back to the VIA. I said in Ghana, we don't use it as a screen and treat approach, which it should be, because the same thing happened with the VIA. Just Georgetown Hospital treat precancerous lesions. So patients are eventually lost to follow-up too. So say I do an outreach in the interior, I am screening patients. I ultimately have to refer those patients out. If they don't have funds or so on, then they're lost to follow up and to getting the service. So they're always, once you're implementing a test, I think, even though I'm saying that HPV testing and the self-testing capture more women, we make sure we have to have systems in place. So once a patient is tested positive, that they have access to treatment, because that's unethical if patients are tested and don't have access to treatment.
We spoke about a number of things, and I know that you're very knowledgeable about other types of gynecological cancers. Could you touch a bit on and tell us the danger of contracting and having cervical cancer? How dangerous is it on a scale of 1 to 10? Because most people don't know that cervical cancer is the number 1 most deadly cancer a woman can contract, and breast cancer is number 2. So could you share?
So that's where I always emphasize, I'll start with this, and I don't think we in Ghana invest as much as we can in terms of resources and in terms of research, investing resources in research. Unlike many other countries, we don't value research as much, and this will go a huge way if we can, because as you would have said, cervical cancer is the number 1 leading cause of death in women. With regards to cancer, number 2 is breast. However, breast cancer is the number 1 in terms of incidence. Mm-hmm. So if breast cancer is number 1 in terms of incidence, the majority of women are having breast cancer. Why aren't the majority of women dying from breast cancer? But why the majority of them are dying from cervical cancer instead? So if we invest in research, mm-hmm. and I think persons are highly underpaid and value isn't added with respect to the importance of having good registry, mm-hmm. and research, because our registry is not up to date in terms of figures. I one figure they might be able to give me 4 years ago or 3 years ago. So research is good, because if we have that, we can be able to say why are most women from cervical cancers dying and not breast cancer. Even though we screen, yes, we screen and we should be able to pick up cervical cancers early, a lot of people aren't having access to cancers. But it has to be something else, because if you're screening more women, then the incidence should go up, right?
Yes.
But why are more women dying? So they have to have challenges in the system, mm-hmm. in terms of access and treatment. And I will say, personally, I've seen patients who probably were diagnosed with cancers, cervical, and they would have received their chemotherapy, which is free, the good thing about it. But in cervical cancer, it has to be given concurrently with radiotherapy. Now, the downfall of this is that radiotherapy is subsidized. So the government only pays a part of it, and the other part the patient has to afford. So if the patient is not able to afford her radiation therapy, she's not be able to receive it with her chemotherapy, and so if the patients aren't able to receive them both together, then obviously the treatment is not going to be as effective as it could. So patient survival decrease. There's also challenges. These are things that I have identified, but we do need research and data to be able to look at these things and analyze. Other things that I've noticed is that when I was in the system and at GPHC, patients are referred out. They had to pay a $4,000 consultation fee with Cancer Institute to be able to see the oncologist. Some of them comes out with no money, and they're not even able to pay. Honestly, I would sometimes pay for them to see that oncologist, so that at least they can start with a chemotherapy. The other thing is that they may be bleeding and anemic and have low blood count, so that they're not able to receive their chemotherapy, because you can administer chemotherapy in a patient with low blood count. And then they don't have access to blood transfusions as readily as they should. And if you're not getting your blood and they keep bleeding, and then at that point in time, we weren't doing palliative or emergency hemostatic, as we would say in medicine, radiotherapy at that point in time. It's only when I further my studies then I know that we can use hemostatic radiotherapy to treat this woman to stop the bleeding. So, as we come to it, cervical cancer is highest in terms of mortality, but once they're detected early, 80 to 90% of those persons in a 5-year time, they survive. The later stages, of course, the mortality decreases, as meaning the later stages disease, people would die and wouldn't live a long time. But also to identify that there are gaps in the system that need managerial approaches, so that basically you can correct these gaps. So patients should, once they're diagnosed, and that's something that could be studied, how long before a patient is diagnosed with her cervical cancer, what's the time period between diagnosis and treatment, or the conclusion of treatment. And if you're able to do that, then you can identify gaps in the system and correct this, because it's strange enough that cervical cancer is not the number one in incidence, but is the number one in mortality. And both of these, breast and cervical, are very aggressive tumors.
Radiotherapy, you touched on that. You said that the government subsidizes. Can you say what is like the estimated cost for?
I can't say, but I can remember a patient was quoting having to pay out of our pocket, because that's another thing that happens. If I'm diagnosed at a private institution, then I have to pay for my chemotherapy and my radiation therapy, unless I'm referred to the public institution. And patient was telling me 1.2, but I think that was out of our pocket. Let's say if it's subsidized and a patient
over
has
$1 million.
1.2 million.
And
But I don't think that was subsidized. That was her pocket money if she wasn't referred to GPHC. So that's the thing. So even though she may have to pay $200,000 and $300,000 when that fee is subsidized, that's still a lot of money for a lot of women. I've had patients who would say, "Doc, I don't even have money to come to the clinic when I'm supposed to receive treatment." And that's the other thing, lodging for these patients and having family support with them, because we don't have a system established where we have strong family support. So your family can be with you when you're having treatment and so on, unlike other countries.
Our time is winding down quite quickly, but we have to touch on COVID-19 and how it has affected the treatment of persons who want to access treatment for cancer, or those who are suffering from the ailment. Could you
Yeah, so I really think this is a really good question. And it has been identified as one of the major challenges in terms of cervical cancer, because there's so much focus on COVID and creating the vaccines, So even the vaccines for HPV, the creation of that vaccines has been on a low. So that's something that needs, I think a memorandum was signed off to increase production of HPV. But yes, that patients who are unable to go screen as routinely as they can because of the COVID. So screening has decreased also, and this is not just Guyana. This is the entire globe. That and also treatment. So patients, during the COVID, most of the hospitals and so on were basically doing private emergency surgeries. So if a patient was diagnosed with cervical cancer or any other cancer for that matter, because it's not an emergency, priority wasn't given to that case. So it has affected all levels, from the prevention to the treatment, because the COVID has just more efforts are being played in terms of protecting people in terms of COVID. But that has caused, the repercussions in terms of cervical cancer, where patients aren't getting their treatment, aren't getting their screening, don't have access to the vaccines because they're just not being produced.
I would have asked you earlier about the other types of, I'm not sure how many other types of gynecological
Cancers.
So
gynecological cancers, we basically do cancers I basically manage cancers of the ovaries, the tubes, sometimes primary peritoneal cancers. So that's cancers to the abdominal cavity. We do vulva, vaginal, cervical, uterine cancers. So all the cancers that has to do with the reproductive tract. So that's the cancers that I manage.
Okay.
So you want me to elaborate? We have time to touch on any one of these cancers?
No, not really. But
Okay.
what I wanted to ask though is I wanted to ask more about. You talked about surgery. How I'm not sure how that is done, and could you elaborate on how?
Okay, so generally, in terms of cervical cancers and surgery are done in the earliest stages of cervical cancer. And it's also important for women to know there's fertility sparing surgeries. So if that, and that's not option that's available because persons aren't trained in this field. So if I'm 25 and I'm diagnosed with cervical cancer and I want to have kids, I don't have any kids, and it's an early stage cancer, there are fertility sparing approaches that I can use. So there are different things that you can do, treatment that's available, surgical treatment that doesn't involve taking out a woman's womb or castrating her, but conserving them so that she can have children. So earlier stage cancers are generally treated with surgery, but later, but if, for example, the patients, for whatever reason, depending on the results of the biopsy, if it's close, the cancer is close to the margin of the surgical margin or so on, if it's invaded the blood vessels and so on, those patients will still need additional treatment. They might still need radiation and chemotherapy. Subsequent later stages disease are generally treated with chemoradiation. And that's an important thing to know, because a patient can be cured in her initial stage with surgery, and she can be cured in her later stage with chemoradiation therapy. That's why staging is very, very critical. And I might be the best surgeon, but if you can't properly stage a patient, then you might treat her, wrongly, and then you won't help in terms of her survival and reducing her relapses.
And when you talk about coming to a stage of complete, what do you call it, being basically cured, what do you need to follow up? Does a patient need to follow up? Because most times I know that persons with cancer or even other types of ailments, they go to surgery or they go through the treatment and they seem to be in a state where they're in the clear, but they still need to go and follow up with the doctor.
Yeah, they should. It will depend how, how early the patient was diagnosed, and it will depend on what her biopsy results came back and say. So if you think this patient is not at high risk of recurrence or for the cancer to come back, then the checks and the surveillance, they're less frequently done as persons who are diagnosed with later stage diseases or at high risk of recurrences. So generally, the guide is for the first 2 years that the patients have every 3 to 6 months, the patients are seen for the first 2 years. For the 3rd to the 5th year, they're seen every 6 to 12 months. And then after that, they're seen yearly. And generally, it's very important that practitioners, that they teach patients what are the signs to look for in terms of recurrence, because you don't really indicate CT scan routinely and so on. But what you need to do is tell these patients, okay, if you have vaginal discharge, bleeding, if you're having some pain, if you're losing weight, if you're not eating as well, those are signs that say that, the disease is back. And so patients might be given a time to come back in 12 months or 6 months, but if that happens, she needs to know that she needs to come sooner, and that this can be a symptom of her having, the recurrence of her cancer. So it's important for practitioners to let their patients know what are the signs and symptoms to look for, and for them to be able to, routinely come back and get their screening and follow up. As I said, it will depend on how aggressive and what's her staging. That's the frequency in terms of how often she should come back.
You spoke about fertility and treatment once you're diagnosed with cervical cancer. How are you? Is a person at risk in terms of fertility when it comes to being diagnosed and having to go through treatment?
Yeah, definitely. So, as I said, if you're in very early stage, you can have your cervix removed, and that can prevent you from can treat the disease, but also it can make you, you still have your womb, you still have your ovaries, so you can still have kids. So those are fertility sparing surgeries. There are other types, but I wouldn't go into them. And you asked some other questions.
No, I was asking you, how high at risk is a person who has this sort of cancer?
Yeah, in terms of losing their fertility. Yes. And well, the other thing is that they generally, if their diagnosis is a little more advanced stage, then they will have their uterus removed. And if they have their uterus removed, then they can't bear children. But also there's options. I mean, there are options where in the case that a woman has to have a hysterectomy and subsequent probably radiation therapy, that to prevent the ovaries being exposed to the radiation, you can, take the ovaries, or what you call ovarian transposition, take them higher so they're not in the field where they're exposed to radiation. And a woman can probably do other tests where she extract her eggs and do different surrogates and so on. So she still have options, but it's important to know these things. Okay. Yeah.
So therefore, what you're saying in a nutshell is that you have options in
Yeah,
treatment.
they have options. You have options.
Protect you in terms of your fertility, that you wouldn't have to later on, if you decide you want a baby, you won't have that just to worry about.
Yeah, you have options depending on the stage in which you're diagnosed. Because if you're diagnosed with a later stage, then there's no option in terms of fertility sparing, in terms of preventing you from,
You touched on support services. We're coming down to the end of our program. You touched a bit on support services, and you spoke about having family, the healthcare system that allows that kind of, and even an awareness that families should be aware that this is something that they need to be more involved in. I believe that most families, if they hear that a person close to them has cancer, they would reach out and try to do as much as possible. But I'm not sure in actuality what happens, and given your view from where you sit, you would know what goes on and how our healthcare system, or public healthcare system, a matter of fact, handles or accommodates that sort of setting for families to be there for their loved ones through a difficult time.
I think if you ask any survivor, they'll say that what has been their one of the factors that increases them or made them want to fight and so on is having a good, strong support system. So this can be your family, a church group, a community, different forms. There's some, I think Kaieteur Cancer Foundation has a survivor group. This is motivation, because these women would suffer, complications and so on, and somebody might know, okay, you go to this person, you can get help, or I did this and this helped me, so that really is good. But in terms of the public system, there's still so much we can do. And in terms of these patients, we're talking about support system, but there's also palliative care that needs to be go hand in hand, because from the time a patient is diagnosed, she needs to have somebody who can meet her spiritually and emotionally and so on, because you have to be mentally in the right place to want to fight this and survive this. Mm-hmm. And that's what we don't have. We don't have that. I've seen patients when I was at GPHC that will come to the clinic, and I have to give them a diagnosis, and they have absolutely nobody there. For me, that's the worst feeling, that you have to tell somebody that they have cancer, and they have no family there to hold their hand, and you have to do that. And I think people need to know that they need to be there with their family also, and incorporate more in terms of support for these patients during their surgery, during their radiation, during their chemo. Because I'm in Escobar and I come to town and I have to get my treatment, and if my family don't have accommodation, where to stay, who's going to support me? There's nobody there when I'm getting my treatment. And I've seen that happening a lot.
And there are a few foundations who help out in terms of support. The Periwinkle.
Yes, the Survivor Periwinkle Club.
I think the Beacon Foundation and a few others. I'm sure that we can do something that will help to boost that sort of support for persons, not just for cervical cancer, but other types of cancers as well. So that brings us, listeners, to the end of our program. I'll just ask Dr. Samuel, just before we go, we have about 1 minute, Dr. Samuel, to share a bit more on how we can get more information if you need more information about cervical cancer and even gynecological cancer, how you can get in contact with her, how you can learn more from the public health sector, and so on. So go ahead, Dr. Samuel.
That's a hard one for me. Well, honestly, I am available anytime. I have a page on Facebook, Dr. Shivani Samlal, where persons can message me anytime. I'm there to answer whatever question that they might have regarding anything gynecological. I'm there. But in terms of awareness, I think all of us using forums like these can play our part in terms of spreading awareness. It doesn't have to be me. It doesn't have to be you, but it can be a person who had a Pap smear today and probably were diagnosed and had her with a precancerous lesion, and she she could have had her treatment and she knows she's cured from cervical cancer, and she can go ahead and say, if I didn't have my screening, I wouldn't have known and be treated, and cervical cancer wasn't going to prevent me from getting cervical cancer. So I think each of us have to do our part, and it's not just me and you, it has to be each and every one of us, and the effort to come out and get screened. Screening is very, very important, and I'll say, for each of us to do our part in terms of preventing cervical cancer.
For those of you who didn't know, earlier this month we would have had World Cancer Day. So Dr. Samuel's little nudge to getting screening is part of that, spreading that awareness. So that brings us to the end of our program, and we would like to thank all the listeners for tuning in, and Dr. Samuel for being here. We know she has a busy schedule. Most doctors do. And we just want to thank you for listening to us and accommodating us in your homes, your office, in your cars. Do have a wonderful rest of the day, and see you next time.
Thank you.